Good morning, councillors, officers and viewing public. Welcome to this meeting of the Health and Social Care Overview and Scrutiny Committee. May I remind members that the meeting will be webcast for live or subsequent broadcast by the Council's YouTube site, and that members of the press public may record and take photographs, except where they are confidential or exempt items. Can I remind officers and guests joining us on Teams, please keep cameras and microphones off unless you're speaking, and please use the raise hand button to indicate that you want to speak. So the next thing I need to ask is, do members of the scrutiny officer are they aware that there's been any apologies? Okay, thank you. Declaration of interest. Can I ask members firstly if they have any declarations of interest before I make one myself? No? Okay. Thank you. I need to declare that I have a pecuniary interest for item 7 due to working for a mental health provider. I need to leave the room for that item. I have asked Councillor Pocock if he would take over the chair for that item, which is kindly agreed to. And so what to need to know is somebody prepared to second Councillor Pocock to come for that item. Okay, agreed? Okay. Thank you, Councillor Pocock. So we then come on to action notes and matters arising. We've got 2 action notes for December 21 and January 22. So can I ask members if they've read through them and do they feel they're an accurate reflection of the meetings? And are there any matters arising from these? Wanting to add at this stage will be a full update on the actions and matters arising at the next in-person meeting, which will be in March 2022.
First question, yeah, I think it's an accurate summary of both meetings. The second point was raised, which is on the first set of minutes, page 4, last bullet point of that page. We were asking for a map to be circulated about the alignment of PCN's primary care networks in the clusters of GPs and localities. We don't have that map, I don't think. Could we ask whoever can supply it to circulate it?
Okay, if you could follow that up, and then once we actually get that, so we can actually pass it out to members as soon as possible. Thank you, Councillor Pocock. Any other points or matters arising? Okay, thank you for that. The first section is on the Birmingham Sexual Health Services. We've got presentations from Dr. Colby and Dr. Marion Gibbon. We've got 40 minutes in total for this item, so could I please ask the presenters to aim for about 10 to 15 minutes for the presentation to give adequate time for questions. So to yourselves, Doctors Rees and Gibbon. Thank you.
Yes, thank you. Thank you, Councillor Brown, and apologies, Marion's the doctor, I'm not a doctor, unfortunately. Kerry, do you want me to share the presentation?
You wouldn't mind, thank you.
Okay. Right, so good morning, everybody. My name's Carl Bees. And today, myself and my colleagues are here to update you on the Sexual Health Treatment and Prevention Service in Birmingham, which is the umbrella service delivered by University Hospitals Birmingham, UHB. And as part of our submission to the committee, we've provided sexual and reproductive health contextual data taken from PHE fingertips, which includes maps detailing chlamydia detection rates, diagnosed HIV prevalence and teenage conceptions. We've also provided a summary profile of local authority sexual health, which is the Splash report, and our colleagues at Umbrella have also submitted a summary report for the period the 1st of August 2020 to the 31st of July 2021, which is a contractual year for themselves. And my colleagues here today, as Councillor Brown alluded to, are Dr. Marion Gibbon, who's the Assistant Director for Partnerships, Insight and Prevention within Public Health. Farrett Raymond, who's a Senior Commissioning Officer for Adult Public Health Services, Maureen Black, who is the Umbrella Service General Manager, and Meg Boothby, who is the Umbrella Clinical Service Lead. And in terms of our presentation, I'll deliver slides 1 to 3 and slide 7. Marion will deliver slides 4 to 6, and then Maureen the remainder of the slides from 8 to 12. So moving on to the first slide. The Umbrella Sexual Health Service is jointly commissioned by Birmingham City Council and Solihull Metropolitan Borough Council, and the contract's been in place from August 2015. It's delivered by Umbrella, led by University Hospitals Birmingham NHS Foundation Trust. It was a 5-year contract for the period the 10th of August 2015 to the 9th of August 2020, with a 2-year option to extend on top of that period, exercised via delegated authority. And then BCC Cabinet approved a further 7.5-month contract extension in July 2021. That was predominantly due to public health support in the BCC COVID response. So the new contract has an end date of the 31st of March, sorry, the current contract has an end date of the 31st of March 2023. And just in the tables there, I won't go through them all because this has been shared prior to this meeting. Just listing the contract values. I think the most important one to look at is the figures for 2020 and 21, and then for 2022-23 is just over £14 million. And we've included a core city cost comparison there, comparing Birmingham against the core cities. Birmingham is round about just above the median average at £14.54 per head, against the lowest spend of £9.81 a head. So we're roughly in the middle in terms of that contract spend. And just to note, the annual contract values from 2020-21 up to the end of 2022-23, there was a 5% reduction agreed and applied. So as you can see, 2019-20, it was just over 14.7 million, and now the amount spent is just over 14 million. So in terms of sexual health service requirements, we've got a statutory duty to commission open access sexual health services, sexually transmitted infection testing, STI testing and treatment, and advice and access to a broad range of contraception and advice on preventing unplanned pregnancies. And the key outcomes within the contract, and these are based on the Public Health Outcomes Framework and locally agreed outcomes, are increasing the use of good quality contraception and reducing under 18 conceptions, reducing the late diagnosis of HIV and the transmission of STIs and bloodborne viruses, providing better access to services for high-risk priority groups, improving support for people who are vulnerable to and are victims of sexual coercion, sexual violence and exploitation, and increasing the chlamydia screened diagnostic rate in the 15 to 24 age group. So I'll just hand you over now to Marion, who will talk you through the 3 outcomes that are listed on the Public Health Outcomes Framework. So over to you, Marion.
Thank you very much, Carl. So as you can see, our conceptions rate for under 18s has been declining. And in fact, Birmingham has done better on this than when you compare it with what's going on across England as well. So I think this is one of the things that I feel is a real positive outcome for Birmingham is that, however, I would say, even though that this is coming down in a very good trajectory, it's not something that we can have any complacency about. And we are going to be considering how we will improve this situation even further in terms of the work that we undertake with teenagers around pregnancy. Now, in the same way, our like late diagnosis of HIV has also been decreasing, and again, it's a good news story for Birmingham. And the other thing that I think plays into this as well is the funding that we've got for our fast track for HIV, which is also something that enables us to do things in an innovative way. If you go on to the next slide for me, Carl. So with our chlamydia detection rate, we've made a lot of progress across, and up until 2019, we were going really well in terms of our national target of 2,300 diagnoses per 100,000 for the 15 to 24 age group. But this has actually been impacted by COVID and the supply side because of the STI home testing kit shortages that have taken place over the pandemic. And so this is an area that we're particularly looking at and focusing on in terms of our performance outcomes going forward, because it's not been as helpful for Birmingham, and we want this situation to improve. So in terms of our core city performance comparison, when you look at us against the 8 core cities, our reduction in underage conception has Birmingham ranked 2nd highest. In terms of our late diagnosis, Birmingham ranks 4th highest, and in terms of our chlamydia diagnosis, this is the area where we're not doing so well, and we are our action planning around how we will improve the situation, and our provider umbrella is working very closely with us in terms of undertaking a promotional campaign during this month, and you will be using social media and looking at how we get the 154 pharmacies that provides services across the city engaged with this campaign. Thanks, Carl. So in terms of our future plans in terms of HIV, we are really focusing on HIV, the pre-exposure prophylaxis, and prevents the transmission of HIV, and is really important in being part of our prevention service alongside what we do in terms of making sure that people look after their health, use the condoms regularly, make sure that they test on a regular basis, and wherever it becomes necessary that they get treatment at the earliest possible time possible. And our routine commissioning of PrEP is with Umbrella. It started in October of 2020, and that at all times the targets that they've been set have been exceeded. And we have got increased funding from UK Health Security Agency to ensure that we increase the numbers and are able to target the key risk groups. So as I already mentioned about our fast track cities, and one of the reasons why we're doing so well is that we're part of a global initiative that's there's 4 partners involved in this: the International Association of Providers of AIDS Care, the Joint United Nations Programme on HIV and AIDS, and the UN Nations Human Settlements Programme and the City of Paris. And what this Fast Track Cities is about is a whole city approach to eliminate and eradicate all new transmissions of bloodborne viruses, and that includes all the different hepatitis, HIV, along with TB. We've been doing some really excellent community engagement work as part of this programme, and the needs assessment is currently being finalised. And what we're hoping for is that Birmingham will be awarded the fast track city status by early August of this year. We're looking to make sure that we commission services where there are gaps and that we change our pathways to ensure that we deliver efficiencies so that increasing of testing and how we look at how working with our communities is all part of the new service specification going forward. And Carl, if you go on to the next one, and then you're going to take over from here, aren't you?
I am. Yep. Thanks, Marion. Yeah. So in terms of our future plans, in terms of contract re-procurement, our re-procurement process has commenced. Needs assessment has been completed, and the public consultation on the draft sexual and reproductive health strategy for the period 2022 to 2030 will be publicly consulted on in late March, running into April 2022, not 2023. The final strategy, along with our procurement and commissioning strategies, will be presented to Cabinet for consideration in summer 2022. And sexual health provision for under 13s. The current service does not fully cater for the needs of children under the age of 13 and those with a mental capacity of under 13. And we're working closely with our colleagues at University Hospitals Birmingham to agree robust provision to the end of the current sexual health contract until the 31st of March 2023. That sexual health provision for under 13s is currently managed through a safeguarding process, with referrals being directed to the police and then via the West Midlands Children and Young People Sexual Assault Referral Centre, the SARC, and with the HIV paediatric team at Heartlands Hospital for follow-up STI treatment and support through an informal arrangement. So we're keen to develop ongoing provision as part of commissioning for of an all-age sexual health service from the 1st of April 2023. So that's it from in terms of the commissioning and the public health side of the overview of the contract. So I'll now hand you over to our colleague Maureen Black, who's the Umbrella Service Manager. So over to you, Maureen.
Good morning, everyone. Thank you, Carl, and thank you, Marion. So I would just like to start by providing some context to Umbrella. So we were awarded the tender in 2015, and prior to that, sexual health services had been largely fragmented, treatment-based, and predominantly delivered in specialist clinical centres. Umbrella transformed the model of care into a prevention-based, community-focused service with education and self-care at its core. We now have, as you can see on this slide, 129 Umbrella GP practices and 159 Umbrella pharmacies. In addition, we provide 6 Umbrella community delivery partners. So if we can move on to the next slide, please, Carl. Thank you. So you'll see on the left-hand side a list of the outcomes delivered over the 6-year period from when we were first awarded the contract. And on the right-hand side, a list of the outcomes that Umbrella itself has delivered in our clinics throughout that period. So as I mentioned in the first slide, Umbrella GPs have increased by 40%. So that's from 92 to 129 GPs across the city. They've delivered over 28,000 LARC treatments, that's long-acting contraceptions, and over 3,000 chlamydia screens. Umbrella pharmacies have increased from 98 to 159, that's a 62% increase. Alongside this, Umbrella, in partnership with RSVP, that's the Rape and Sexual Health Project, have made over 14,000 referrals. In addition to the extensive partnership work, Umbrella continued to provide community clinics and our 2 central locations based in Birmingham at Whittle Street and Boots City Centre. Throughout the past 6 years, there has been over 622,000 clinical attendances at our clinics, umbrella clinics. And with education one of our key aims, our clinical educators have trained approximately 4,000 clinical and non-clinical professionals. We have provided over 21,000 women under 18 with contraceptives. And the umbrella brand is well recognised thanks to our bespoke communication team. The interest in the service is clearly evidenced by the over 2 million hits on the umbrella website. You move to the next slide, please, Carl. Thank you. So, despite the challenges that everyone in the NHS and across the whole of Great Britain have faced throughout the COVID-19 pandemic, Umbrella continued to provide a core sexual health service for the 1.1 million population of Birmingham and Solihull residents. And we did this by providing the most vulnerable, clinically symptomatic and urgent patients with sexual health treatment. In addition, Umbrella was the only regional service to maintain a service for reproductive sexual health throughout the pandemic. Despite the challenges, there were over 73,000 patient contacts in year 6. That's from the period August 2020 to July 2021. That represented a 14% reduction in contacts from year 5. However, notwithstanding the positive elements that arose throughout the pandemic within the service, we have experienced challenges, including closures of GPs, closures of our own clinics, and pharmacy closures. We've had staff deployed to intensive care units across the trust and wards. And this has impacted on staff morale, as you would expect. So to combat this, we're working hard with our staff to lift the morale and move forward robustly. So we have staff wellbeing hubs, engagement sessions, and counselling. And since 2020, we've been training our staff in psychological first aid and peer-to-peer support. We also aim to build on the opportunities presented in terms of different ways of delivering our service. And that means having a focus on digital solutions as we aim to build our recovery in the future months. Thank you. Carl, would you please go to the next slide? Carl? Okay, thank you very much. So in terms of our recovery and our future direction, we will build on new ways of delivering sexual health services, focusing on the learning that we've accessed throughout the whole of the pandemic. We'll be enhancing our digital footprint, strengthening our access, and developing our partners and the partnership relationships that have worked very well over the past 6 years. As I mentioned in the first slide, one of the key components of Umbrella Services is the fact that we are predominantly an evidence-based service. We have a thriving research unit, and at the moment, the current delivery research that we're delivering includes understanding the young person's perception of the value of STI kit testing, the patient outcomes for clinical care following a sexual assault, and evaluation of our pharmacy-delivered sexual health, all of which builds on what it is that we regard as being priorities in terms of moving forward with sexual health services. And finally, as mentioned in the previous slide by Carl, there is a tender taking place in the summer of this year, and we will be providing a bid towards that tender and aiming to build on and enhance the achievements that we have delivered to date, and also noting the resilience of our staff throughout the pandemic, demonstrating how far we have come throughout the 6 years and how we aim to build on the learning and achievements over the past 6 years as we move forward. Thank you all very much indeed.
Thank you, Maureen.
Okay, thank you very much for that presentation. I think that was really interesting and informative. So, members,
thank you for the presentations. I think it was really enlightening with the information we've been given, because I'm glad, Carl, that we have the contract spend. I think it's really useful that you show actually as well the comparisons with other core cities. I mean, obviously you're just always going to get differences, and you could ask the question, well, why does Birmingham spend that amount per head when another city doesn't? But you're talking very marginal, small figures. So I think it's just a good snapshot, really. So I think that's really useful. And it just shows where, for the public really, as well as members, what you do with that money. Because I asked that before and you came up with the goods. So I'm really glad you've kept that up, because it just gives members a shot at what the money is doing really. And it's we should ask, because it is, at the end of the day, finance. I was interested when you said about, Carl, about the 2022, I think you said it's 2030. So if Cabinet basically puts that through, are you concerned at all about any, I mean, is it a given? I'm just interested myself that obviously with these statutory services, is it a given that yes, it gets rubber stamped through Cabinet, or you could see some sort of reduction in funding? I know you mentioned that the contract spend had dropped. Are you ever worried? And does, as a commissioner, do you get some sort of notice if that drastically does reduce?
Yeah, yeah. Thanks, Councillor Clancy, and Marion. Feel free to join in as you need to. I think because parts of the service are mandated, the money comes from the public health grant from the Department of Health and Social Care. So it is, for want of a better word, ring-fenced. We get details of that funding every year, but Justin, as the Director of Public Health, will factor in, based on what he's getting currently, potential increases for cost of living inflation. So I don't see the public health grant reducing. I think if anything, Marion, it's slightly increased this month. It's for next year, I think it's increased by about 3%. So we're fairly confident as we can be, that funding will continue. And because it is ring fenced, and of that grant, you've got to deliver certain outcomes through it in certain services, we don't have any concerns about the funding moving forward. What those figures might be is still to be worked on, but that will be factored in by Justin as part of his long-term financial forecasting. So no major concerns from myself. And in terms of Cabinet, just going back to your other point, I think Cabinet understand that we've got to deliver these services in order to reduce health inequalities across the city. So we don't envisage there being any issues in terms of that. The strategy's been co-produced as well. We've engaged with citizens and the People for Public Services Forum. We've got a robust needs assessment behind it. So I think we're as confident as we can be. Is there anything you want to add to that, Marion?
Yes, I think one of the things that I'd like to point out is that we are also in touch. We have been holding discussions with our ICS partners around how we start to consider the place-based aspect of our services. And so those discussions are ongoing, and I'm really confident of the approach that we're setting out and how and we're going to deliver services for the people of Birmingham and Solihull, and we're working also closely with Solihull partners as well. This is going to be on the ICS footprint of Birmingham and Solihull.
Just to follow up to that, thank you, Dr. Gibbon. I mean, obviously, one of the statistics, the chart shows there's been a decline in the Chlamydia, Obviously, during the pandemic, people couldn't mix. I mean, it's just a given. People didn't club. I mean, looking at age groups that are pretty young, it's fair to say my own eggs are all on Zimmer frames now. But I mean, when you've got the young youth, you know, raring to go, and we've had the pandemic, and obviously services. I know the umbrella. I was interested in the umbrella as well. I think that's really good that they're looking at the future direction. But obviously, with the pandemic now sort of coming into, calmer waters. I suppose I'm not a data girl, but I suppose you're checking your data because there will be many more now. We've got more travel happening, we've got more people going abroad, coming back, etc., etc. And obviously the youth like to mingle. So I just wondered, yes, it's declined, but do you forecast a shoot up because people will start dating again?
Yes.
Can I bring my umbrella colleagues in to kind of what's your thoughts on that one? I think so, yes, but just to get from the provider as well.
I'm just trying to link it in with forecast.
Maureen,
I'll just make a few comments, and then Dr. Boothby may well want to add to that as well. I mean, you're absolutely right. I mean, as people start to mingle more, and given that Birmingham has such a young population, inevitably we will see a rise in this area. And we're definitely anticipating that. You know, we've got fabulous campaigns that are coming up. We've had one that's been ongoing from the 31st of January to 27th of February. We've got another campaign in May. We follow that up with a further one in June. And as well as that, we'll have lots of social media going out from our comms specialist also, and linking in with all of our partner organisations as well, particularly Birmingham Youth Service. So absolutely correct. We can't ignore the fact that this will rise, and we have to be prepared for it, and we absolutely are. We've also got, as you know, we've got huge impact in terms of the umbrella pharmacies. We'll be giving a lot of our campaign literature to them also, and encouraging them, so every time that they issue an emergency hormonal contraception, that they also offer a chlamydia test as well. So your point is really well taken, and we are absolutely sighted on making sure that we are we're supported and ahead of the curve in terms of that. Meg, do you want to add anything from a clinical point of view?
The only thing I would just add is that when we're looking there at the chlamydia diagnoses, actually what we're looking for is an increase, because it's really about case finding. And I think over the pandemic, the number of chlamydia tests that we've been able to do has dropped significantly, because, as you say, of the lack of movement of young people, the lack of the previous facilities where they would go to get their testing, in terms of GP, lack of footfall around GPs and pharmacies and things like that. But when we look at our testing data, actually the percentage positives that we've had, even though the number of tests being done has fallen, has actually remained very constant, showing that actually we are still picking up that, sort of testing that the right part of the population. And as we get increased movement in people, increased opening up of venues, we would look to see the number of tests being delivered going up significantly, which will increase the number of diagnoses that are made, and then hopefully that will lead to a stabling, eventual reduction of the prevalence of the chlamydia across the population. So yes, I think the figures are entirely explained by what we've seen in the community over the pandemic, and we are prepared for how that will impact as community opens up again. Thank you.
I understand that Carl wanted to say something. And then to Councillor Tilsley.
Yeah, thank you, Councillor Brown. And yeah, just to come back to Councillor Clancy's point, and I fully agree with everything that Meg, Marion and Maureen have said. I think it's worth noting that Umbrella enacted their current COVID recovery plan on the 18th of October, and all of our clinics are now fully open, offering face-to-face appointments. Walk-in appointments are are being offered as well, which is excellent. So we've literally returned to business as usual. Our GPs and pharmacies are operating now at pre-COVID levels of activity, which is excellent in terms of the fitting of long-acting reversible contraception and the provision of emergency hormonal contraception, i.e. the morning after pill. So I think that's testament to the Umbrella service and how quickly they've managed to reenact their recovery plan. And I think just to mention as well, we're linking in, Maureen mentioned about promotional work. We're thinking about how we link in the sexual health messages to the Commonwealth Games, be it for visitors of the city and visitors to the city and for residents of Birmingham. So that's all being planned for in future campaigns. So yes, and just coming back to Councillor Clancy's points, we monitor Umbrella's data on a monthly basis, so we're aware of all these increases, and again it's getting back to business as usual, which is excellent news, I think, after what, nearly 2 years of uncertainty and restrictions, that there is light at the end of the tunnel.
Thank you.
Okay, thank you very much, Carl. Councillor Tilsley.
Thank you. It's a couple of comments really, particularly as far as the under 18 conception rate is concerned. It's pleasing to see that it is reducing. However, I would make the point that we did start from a very high level. So any reduction has got to be good, and we're still 2.2 above the England average per 100,000. But any reduction has got to be good, so that's commendable. But as Councillor Clancy said, the opportunity for mixing has been somewhat limited, but we'll look at figures in the future. The work that you've done through Umbrella and engaging with pharmacies, very, very good. Pleased to see it, because I've always felt that pharmacies within the community are an underused resource, and the more that we can use them as frontline services to the public, the better, because it's taking some of the pressure off GPs and certainly EU units. And then on Whittle Street, you mentioned Whittle Street in conjunction with the walk-in centre at Boots for giving advice and information. For some time, there has been a question mark over the Boots walk-in centre, and I've always had a particular affinity to the walk-in centre because it was set up by BCHC, and I was the non-exec responsible for the walk-in centre, so I've got some affinity to it. But given that there's been the question mark over the walk-in centre, what alternative provision could you see in the city centre? Because I think it is important. And then the last point, which was the throwaway point that I think Carl made regarding the Commonwealth Games. I was surprised, I would use the word, regarding the amount of contraception that was made available for the last Olympics. So have we got sufficient supplies on that?
Yeah, thank you, Councillor Tilsley. Meg, do you want to respond first?
Thank you. So it was just really, I was going to respond on the point of the Boots city centre provisions. So Umbrella has our own standalone clinic in the basement of Boots. So we operate alongside, but we are not part of the NHS walk-in centre in Boots. So we operate our own clinic down there. So that is not tied in with the future of the walk-in centre. And we found that location has been, you know, incredible because of the ease of access, particularly for young people, with no advertising at all. From when it opened up, actually pre-umbrella stages, young people found that service, and we've expanded that service over our time and now have an education and training centre based there as well. And we work very closely alongside the pharmacists at Boots, such that we can share the provision of services between the pharmacy provision at Boots and our own clinic there. So I feel that provision is quite secure.
Thank you.
And just coming back to a couple of your other points, Councillor Tilsley, fully agree about the pharmacies, and I think the work Umbrella have done around our pharmacy model is excellent, and other areas across the city, across the country, are looking at developing that further based on our model. And pharmacies, we're constantly looking at what more can they offer within the community as a first port of call, rather than going to a GPs, and being far more accessible. And in terms of the Commonwealth Games, yeah, I fully agree about the amount of condoms being requested. We have met with the Commonwealth Games organising committee around contraception and the signpost into services, and what we found is predominantly it's for the athletes and the team entourages where contraception is required, and there was an expectation of 50,000 condoms across the 3 Commonwealth Games sites, so 150,000 in total. So there won't be any issues in terms of supply, and we are due to meet in the very near future with Pam Venning, who is the Chief Medical Officer in charge of the Commonwealth Games from that side of it, just to make sure that we can signpost into umbrella services if need be, or into an umbrella pharmacy, etc. So that is all being worked on. But I must admit, when they say, can we have 150,000 condoms, it makes you realise the extent of it. But in fairness, there's about 11,000 athletes and team members arriving, be that coaches, medical staff, etc. So once you break it down that way, it isn't such a big number.
Thank you, Carly. Commonwealth Games is obviously taking the place of the bicycle in spreading the genes around.
It is. and Marion and Farrett? Oh, you're on mute, Marion.
I'm just unmuting. I just wanted to say about the work that Public Health is doing with pharmacies. It extends beyond the work around with Umbrella, with our other services as well. And so we've got some really good plans afoot, which you will no doubt hear about in our other presentations around public health services.
Thanks, Marion. And Farrett?
Good morning. Thank you, Councillor Tilsley. Just to add to Carl's message around the Commonwealth Games, we know it's not just a Birmingham footprint, and we are working with our neighbouring local authorities to make sure that we've got consistent sexual health messages. So it's not just Umbrella that's going to be taking all of the load. Just make sure that we are working in unison with everyone involved. Thank you.
Thanks, Farrett.
Okay, thank you for that. We've got Councillor Idris. It's a question.
Thank you, Chair. As it has been mentioned a few times over the last 2 years, there's been hardly any demand for the service. But as we are coming out of the restrictions, there may be an explosion of demand on the service. And my question is, I hope that there will be savings made in the last 2 years, and those savings have been made. Are we able to carry into the next years because to cope with the demand in service?
Do you want to take that, Marion, or do you want me to?
Can you just ask that question again, Councillor Idris? I'm not quite sure that I caught the full meaning of your question.
In the last 2 years, because of COVID, there was hardly any demand on the service. So one would hope that there will be significant savings made from the budgets for the last 2 years. But my question is, are there any savings made? And if they are you able to carry them into the next year or so, cope with the demand?
Carl, I think you're best placed to answer that question.
Yeah, Thanks, Marion, and Meg and Maureen, feel free to add to anything I might have. I think during the initial stages of the pandemic, there was directive around national legislation that we carried on paying providers as normal and didn't reduce payments to ensure sustainability, and they weren't put under any financial cost pressures. So that was for the period March 2020 up until October 2020. And I think even though there have been restrictions, we've still been getting numbers, albeit lower numbers, and more telephone consultations. So where we couldn't do face-to-face activity, we were doing telephone consultations, video consultations, postal medications. And in credit to Umbrella, they were doing face-to-face appointments for people who may have been vulnerable or needed to have been seen urgently. In May 2020, which was right in the middle of the pandemic, so they were seeing people face-to-face when they needed to. So although the numbers in treatment may have dropped, we've still carried on delivering a service, albeit in a different way. So a lot of those costs are fixed costs in terms of staffing and buildings. So in terms of cost savings, from my perspective, there haven't been any. Do you want anything you want to add to that, Maureen or Meg?
No, I think you've covered that very well, Carl. You know, we have maintained a core service, and I said in my presentation that we have prioritised the most vulnerable and clinically symptomatic and urgent patients. And we've also been the only sexual health service in the region to maintain a service for sexual reproductive health throughout the height of the pandemic. And despite the challenges we have overall since August 2020 to July 2021, had over 70,000 contacts. So I think that kind of puts us into a fairly stable position as far as we're concerned, and doesn't really impact significantly on savings, as you point out, Carl.
Thanks, Maureen. Anything from yourself, Meg?
No, I don't. I mean, I haven't got anything to add to that. I think, you know, the cost of the service, unfortunately, persist, despite the fact that, you know, sort of the community around us has changed. And we've worked very hard to make sure that we are continuing to offer that service throughout the pandemic in all the ways that we can. Not including, obviously, the online testing, which was huge over the course of the pandemic as well, in keeping people connected with STI testing when they weren't able to physically visit the clinic.
Thanks, Meg.
Okay, thank you. We're in a bit of a time crunch now, and I have two councillors and myself that want to answer questions. So can we be brief with the questions and briefish with the responses? Councillor Pocock.
Thanks, Chair. I'll try and deliver on that. Thanks, Umbrella, particularly for the presentation. A lot of detail here, but could you just give us, from your perspective, the 2 or 3 standout achievements you think you've made in the last year? Maybe 2 or 3 top priorities for further improvement in the year ahead. Just to sum it up. You've got 3 seconds.
Maureen, have you got?
Oh, so sorry. Can you repeat that question? I'm sorry.
The sound quality from the meeting room is quite poor for those of us online.
Yeah, it was, Maureen, it was the 2 or 3 standouts over the sort of last 12 months, and 2 or 3 areas that we'd like to improve.
Okay. the 2 or 3 standouts have been, I have to mention the resilience of the staff, which has been phenomenal. I would also have to say the ability to maintain the service and see the number of contacts that we've had, and also the way that we have adapted the service, the third point, in terms of changing our pathways, our telephone consultations, using digital applications as far as we can. Meg, do you want to?
Yeah, the one thing I'd highlight is the fact that in the midst of all this, from October 2020, we actually launched the PrEP service, which was a service that wasn't in existence before, because PrEP previously was only being provided through the research trial Impact. And so throughout this, we've actually embedded within our day-to-day routine sexual health service the provision of PrEP. And as Carl had said, the targets that we've been set have consistently achieved and exceeded those targets. So there's now a huge number of people who are accessing and safely receiving PrEP who previously were not, which I think is a massive benefit to the community, and a real achievement that I'm proud of, that our service has managed to deliver in this really tough time.
And I'd like to point out that they have been nationally recognised for the way they've provided services across the country, and which they're too shy to say. But I just want to make sure that it's pointed out.
Thank you, Marion.
No, thank you. And anything in terms of improvement, Maureen or Meg? I suppose I know we're constantly developing our pharmacy offer, aren't we? And we'll be looking to increase chlamydia testing. Is there anything else from the umbrella side in terms of improvement?
Yeah, we're always looking for innovative ways to deliver the service, and I think one of those areas will be definitely the digital element. For example, we're looking to introduce a project called Health Chat, which will enable young people to text with any issues that they have and have a confidential service that way. And I know that that's worked extremely well in other specialist areas such as mental health. So that's absolutely critical. And also, I mentioned in the presentation the work that's taken place within our research unit. So we'll be looking to see what the outcomes of that are and how we can translate that into service delivery moving forward. And listening to people out in the community, listening to the young people, listening to our partners, hearing what it is that they're saying, and seeing how we can respond accordingly.
Thanks, Maureen.
Thank you for those responses, and thank you for the question, Councillor Pocock. Councillor Islam.
Thank you, Chair. It is a very simple, not a question, just for clarification, because he mentioned umbrella citywide promotional campaign did in February 2022, utilizing social media key location and 154 pharmacies. Yes, I do understand. What I'm just trying to understand, because we got a lot of even young people, those who joined this country or now entered the United Kingdom recently in Birmingham as well, actually in my ward, Africa. So there are lots of young people. I'm not saying too many, but at least some young people do not speak English or do not understand English. So is there anything else, when you the advertise or whatever it is, during your campaign, use any other community languages? Thank you.
Yeah, thank you, Councillor Islam. I can start off, and Maureen and Meg, if you need to come in. I think throughout the pandemic, public health started working closely with 19 different community organisations across Birmingham, be that Eastern European communities, African communities, Asian communities. So we liaise very closely with those communities in terms of how we put messages out to people so it's accessible, so it's understandable. And we're constantly in touch with the Umbrella Communications lead about how we do target what might be termed as harder to reach communities where English isn't the first language. translation services are available as well within Umbrella. Anything you want to add to that, Meg or Maureen?
I mean, I think what I would say, our campaigns are often very visual, as well as, you know, sort of word based. And I think that's a strength in terms of the brand being recognised. And as Carl said, you know, our brand it's you know, it's on the big screens, if you like, through the city, but also embedded within the smaller and within the communities, such as with the pharmacies. So where people see and recognise the brand and may recognise some of the visual imagery and graphics, they're able to then follow that up in their local communities, where they would have people who can talk to them, hopefully in their own language as well. So it's one of those things that's an endless discussion around how you best do that in terms of, you know, translation, because obviously not every language can be covered. But we do try and use sort of imagery that we think will cut through beyond language to hopefully give that brand recognition, so people can then go into venues in their local community and know that brand is associated with sexual health, and they can find help and advice there.
Thank you, Meg.
Okay, thank you very much for the question, Councillor Islam, and thank you, of course, for the answers. I've got two brief questions to answer myself. First, the first one relates to reducing under 18 conceptions and reducing the late diagnosis of HIV. It was a follow-on to a question that Councillor Tilsley put and your comments on fast-track cities. Do you have any information how Birmingham compares to European cities of a similar size? And the second question, again linked into Councillor Pocock's, I think, you've obviously made a large increase in the number of umbrella GPs and umbrella pharmacies you've developed over the last 6 years. What percentage of the population or city do you now think you're reaching? And what percentage do you still think you need to expand to number-wise in terms of practices and GP linkages? So thank you.
Thank you, Councillor Brown. Marion, do you want to take the first question on fast track and how we compare to European cities?
What I will do is ensure that a slide is put together that we'll so that I have the exact figures at my fingertips. So I will ensure that I take that back to the KEG team and get that data for you. So the next point.
Yeah. No, thanks, Marion. And yeah, if you could put that down as an action for us, Kerry. In terms of GPs and pharmacies, I mean, I'll bring Meg and Maureen in on this. I know based on when we've plotted where these pharmacies are and GPs, we have got a citywide coverage across every council ward. Anything you want to add, Maureen, in terms of GP procurement and pharmacy procurement? I know GPs and pharmacies are contacted regularly to ask if they aren't a member of the umbrella partnership, if they want to become a member. It's just anything you need to add to that, Maureen?
No, not really. I mean, I think the coverage is, as you point out, Carl, is widespread. I mean, obviously there are going to be pockets of the community in terms of the hard to access communities that we'll need to focus on drawing in more. But as far as possible, we've had two tenders, the pharmacy and the GP tender, only recently over the past 2 years, and the whole aim of that was really to extend the reach as much as possible. But it's certainly not something that we are complacent about. I mean, we do monitor the statistics in terms of who it is that we're reaching as a percentage every year, and we'll continue to do that. Meg, do you want to add?
Thanks, Maureen.
Yes. The point I would add about the GPs is that although we link with that number of umbrella GPs, a number of those GPs also will provide services to those patients who are not registered with their practice. So it doesn't mean that if you're not registered with an umbrella GP practice that you can't access umbrella GP services. And when patients contact us about particularly the LARC fitting service offered by GPs, they will be signposted to any umbrella GP within their locality and advised of those who will see patients out who are not on that GP list. So the coverage actually extends outside of the patient lists of those particular GPs.
No, thanks, Meg. And I think one final point from me, based on Maureen's point, was just on the working with those community organisations to make sure that we are getting consistent messages out to those communities about go and get advice at a pharmacist, or you can see a GP, etc., etc. So I think between that coverage we've got with GPs and pharmacies and working with those 19 community organisations, we are getting a consistent message out in regards to sexual health, be it for testing for STIs, or be it for reproductive sexual health.
Okay, well, thank you for the answer to that question. That's really appreciated. And if you could get figures over to Kerry, I would appreciate that as well. And can I thank you all for the answers, the report you gave, and the comprehensive responses you've given to the questions that members asked. So thank you very much for your time.
No, thank you all, and nice to see you all.
Thank you.
Yeah.
Okay, I think we're now due for the period poverty and raising period awareness tracking report. And I think we've got Marion Gibbon and Joan Bradley are coming to do the presentation on this. We've got Marion and Joanne, you with us at the moment? So we've got Marion and Joanne with us at the moment, so thank you for that. And you're going to give a tracking report on the period poverty and raising period awareness. Yes.
Thank you. Joe, have you got the report for us, please?
It doesn't appear to be on the call, Marion.
Can I ask you to, because I've just been focused on sexual health, if I could have 5 minutes and I can get the report and then I can share with you.
That's fine. Take the time you need.
Brilliant, thank you.
Yes, somebody's on for that one.
Okay, would it be beneficial if we move on to item 7 to give you a little bit of time, and then you come back in?
Yeah, that would be great. Yeah, thanks very much. Sorry about that.
Okay, so we're now going to go to the Pershore Road Residential Mental Health Rehabilitation Unit, where we've got Robert Devlin and Martin Luke and John Bairstow going to present. Are we all there?
We are, yeah, thank you. Welcome. Well, it's actually John Bristow. He's representing Mind in Birmingham. My colleague Martin Luke represents Pearson HFT, the Mental Health Trust, and I'm from Commissioning.
Okay, and you guys have the report now?
Yeah. Okay. Breaking up a little bit there, but we'll get straight onto the presentation. So hopefully you've had time to read the paper that was prepared and sent through. So we'll just build on that a little bit in the presentation. I'm going to cover off a bit of the background, and John will tell you a bit around the current service. Martin will just allude to the proposed new service that we're hoping to repurpose Pershore Road resource into. So we started a piece of work in BSOL it's around about 3.5 years ago now, where a multi-agency group got together to look at the issues that we've got within the system. We've got a considerable spend on 117 and out of area places for people requiring rehabilitation. We felt that we could bring that together and do something better with that resource. And it's fair to say that we've made pretty good progress throughout the time, working as a group together in a kind of transformational sense. And this is just one component really of what the overall plan is to do, which is to produce an integrated care pathway for rehabilitation for people with serious mental illness. As I said, it covers Birmingham and Solihull. And what we're talking about here really is the most vulnerable of an already vulnerable client group. So there's 15,000 people on the SMI register across the PCNs. But really this transformation concentrates on around about 400 to 500 of those people who with the most chronic conditions and who have had the most inequalities to deal with in their recovery. So the first bit that we concentrated on was that out of area bed use. BSOL was criticised by CQC back in 2018 for the amount of out of area placements that we had. Since that time, we've been doing extensive review work of the facilities, targeted work with individuals to look at their needs and to see where and if we can provide for them back in the city. We've had some success with that. We've stemmed the flow of new people going out of area. We've had a few people who've decided that, you know, they've been out for a while and they want to stop where they are. But it's fair to say that we've brought about 40 people back into at least the West Midlands conurbation, and we're still working on whether we can set up new provision actually in the city. But that's not what we're talking about today. And the other key driver was looking at the experience when people do step out of hospital into the community and what that offer looks like. And up to now, it's been difficult to access individual tenancies in a timely fashion and in the areas that people want. So that was something that we tried to build into the model. And John will mention a little bit about that as we go forward. Can I have the next slide, please, Dario? So why change the model? Again, it's fair to say, I think rehabilitation has been an area that's been tended to be sidelined over the last 15, 20 years, 25 years even, while the functionalised model come in for mental health, which concentrated on home treatment and assertive outreach. And really what we're left with is a very fragmented approach. We've got a hodgepodge of services out in the community that don't really connect up with each other. And we think this is the time now that this needs to be addressed. There's a recognition nationally of this. It's not a Birmingham issue. In fact, we're better than some. But there are a number of drivers going on, not least the long-term plan, which references recovery and rehabilitation services. The Getting It Right First Time programme, which we're a member of, and we've had an extensive deep dive from them to support us in our thinking. And those are the key programmes that we're linking into, as well as NHSE, who are very interested in the work that we're doing as an exemplar within the national setting. So as I mentioned about the fragmented approach, we've had a lot of people out of area because of it, and we have long lengths of stay in hospital. And we've got quite an old-fashioned model that is based around settings that are, you know, group settings, and that's becoming, there is a place for it, but it's becoming increasingly not the desired option for people, and we're especially seeing that with the younger client group who are coming through. You know, people are aspiring to having their own place and that the support should reach into them. So that's the big driver in the thinking. And as I said, we're developing that multi-agency system pathway, which is hospital right into the community. Can I have the next slide, please, Dario? So I'll hand you over to John, who will just talk about the current service, Pershall Road.
Thank you, Rob, and thanks for the opportunity to speak this morning. concerning the Pershall Road. I think it would be helpful just to kind of set the scene for colleagues and give some background information to Pershall Road, the current service that is a residential care home for up to 10 individuals. And Pershall Road is registered and regulated by the Care Quality Commission, and it currently has a good rating by CQC. As the slide indicates, the facility is primarily for people with longer-term serious mental health issues under the Section 117 arrangements, very much a step-down facility from inpatient settings. The majority of the referrals to Pershall Road do come through the Birmingham Solihull Mental Health Foundation Trust, and particularly their Steps to Recovery service. In terms of the environment, I'll say a bit more about that as we go on, but the primary purpose of Pershall Road is to provide accommodation and support with helping individuals, adults, to maintain their recovery and a stable mental health condition, and also to acquire or reacquire those day-to-day living skills that are needed for people to live more independently in the community. In terms of the environment, people, residents in the home have their own bedroom, but they share all other facilities, so there are no ensuite facilities. The home does have some communal, large communal areas, but there are no ensuite facilities currently in the home. It's in terms of how long people stay in the home, it's up to 18 months, and during that time, my colleagues and staff at Pershall Road would be working with individuals and alongside our partners to help people to become ready to move on, and to move on to potentially other types of supported accommodation. And some of that would include Birmingham Mines supported housing offers, but also with other housing providers around the city. If we could go on to the next slide, thank you. In terms of the current picture, let me start by saying that we don't currently own Pershall Road. The property is owned by Midland Heart, and we act as a managing agent for Midland Heart, the landlord. And as some of us are aware, Midland Heart made a decision a few years ago to disinvest in their care and support facilities. And so there has been some real challenges around the limitations that the Pershall Road has at the moment, particularly, as I mentioned earlier, no ensuite accommodation, shared facilities. We have not been able to attract any female applicants to the home. And this has also impacted on what we're calling the underutilisation, i.e. the overall occupancy and referral levels to Pershall Road, which over a significant period has led to a number of vacancies. And that's primarily because of no ensuite, and the facility, the home as it is not very attractive to, as I said earlier, female applicants. Midland Heart, as I said, are currently the landlord of Pershall Road, and they are looking to dispose of the building. and we have also started to have conversations about them in terms of whether or not a feasibility study we've undertook about whether or not we could purchase the building from Midland Heart and redesign the environment to offer self-contained properties, possibly for the use of this initiative in the community transformation initiative. The other thing is we've had a very stable staff team there for a number of years, highly skilled, and in terms of the changing need for an intensive community rehabilitation offer, this creates a real opportunity to utilise the skill set of the current staff team who are working at Pershore Road. If we could go on to the next slide, please. So I just wanted to take the opportunity to say a little bit about the conversations and consultations we've had so far. As you would expect, that's a really important piece of work to do in terms of a redesign or a change in a service. And we've had now 2 meetings with the staff there, consultation meetings. I have to say it's been a challenge given the up until recently the restrictions around COVID, and also the home was for a period of time in lockdown due to an outbreak of COVID. But despite that, we've managed to meet with staff over. We had 1 physical meeting, face-to-face meeting, 1 Zoom meeting, and the feedback we've had is generally very, very positive from staff. Some apprehension about what the new service would look like, and you know, potential changes to some of the terms and conditions, but generally, and that's to be, I think that we understand that, but generally the feedback has been very positive. In terms of the residents, we have now had a consultation with the residents, and that's gone really very, very well, and the feedback that we've had from residents has been very supportive of this initiative. I mean, comments like, they see real positive for them to have their own front door, not sharing facilities or communal spaces. Other comments about, well, I would not have to feel that I need to get on with other people around me in such a small space. Some comments about that 1 or 2 people felt that sometimes the care home setting is just a replacement of hospital, where you have to share facilities and get on with other people. Also recognising and understanding that general things that some take for granted, like managing their finances, use of technology, communal facilities, can be very strange for people who may be in hospital for a number of years. So that's also something that people have fed back that they would like to continue to receive in terms of the support around benefits, around financial support with IT, but also importantly, flexibility of support from staff. They generally, the feedback was one of very positive, and particularly people feeling appreciated that we are looking at options for redesign of Pershore Road, and generally, as I say, a very positive response, and particularly because people are looking for the opportunity to have their own front door, independent accommodation, independent living, but with the wraparound services of the Mental Health Trust and ourselves as the care and support provider. We've also had lengthy discussions with our trustees at Birmingham, and again, very positive response and very supportive of the proposal around the redesign. And of course, we've also been involved now in the integrated system governance, and particularly with the Intel CCG board and wider agency and transformation board. So we've done a lot of work in terms of talking to colleagues, talking to service users, our trustees, our staff, and our partners and colleagues, and overall the feedback has been very, very positive.
Thank you, John. Going to bring Martin in just to talk about the new model.
Yes, morning members. Thank you for giving us the opportunity to talk about a part of the initiative, the intensive recovery team, which is something that we've been working on for probably 18 months now, and we feel really excited and passionate about. As Rob mentioned earlier, it's become really evident nationally about not only the spend but the outcome for service users in terms of out of area placements, and the fact that people could be spread up and down the country in various establishments, and really what's been delivered and what the outcome for service users has been brought into question. So working with both the NHS England, the Royal College of Psychiatry and other authorities up and down the countries, we've developed a model based on an intensive recovery team, which, as John's mentioned, will assist supporting service users with needs in the community. So what's different about this model? I guess the first thing is that the people will be assured of a high quality tenancy, which will be long-standing and will give them the opportunity to really live where they want to live. But around that, there'll be considerable support to enable people to have better outcomes. And by better outcomes, we mean an increased range of interventions, access to housing, to family relationships, to financial support, to employment, education. Also the traditional things like symptom management and crisis management. And as we've said, we've really gone back to basics on how we've worked out this team, looking at how many hours of provision people could need up to in crisis and building the team around that. So what do we hope to achieve by this? But not only in terms of better outcomes for service users, but obviously reducing the spend that the health economy is currently spending on out of areas. And we're confident that we can achieve this. As Rob's alluded to already, we've already had some success in enabling people to return to the local area, but we still think there's a lot of work to do, and this team really impinges on our ability to do that. And as we've said, from other areas in the country, they have been very successful, with some areas completely eradicating the need for such placements. The other thing is we've also currently got a lot of investment in some of our existing rehabilitation units for quite long lengths of stay. And whilst we're not advocating in any way the closure of these units or loss of services, we are confident that this will offer people an alternative to admission, but also reduce the lengths of stay, so people will still require some level of inpatient provision, but for nowhere near as long as is happening currently. We'll also be basing it on a trauma-informed approach to really assist people in managing the trauma and managing the crisis that's been experienced over a number of years. I guess what's different about this model is we've really gone back to basics in terms of the skill mix and how the team is structured, with considerable reliance on the recovery workers, peer support workers, to try and, I guess, turn upside down the traditional model of psychiatry where services are delivered to people rather than in partnership, and we feel that we really can embrace and capture this. And obviously, because the team are so embedded and working so closely with people, hopefully we'll be able to alleviate the necessity for people to end up in crisis and the consequential usage of A&E and other crisis services by early detection and early management of mental health situations. And obviously the overall aim, and this is pivotal, is support flow through the overall pathway, avoid blockages, enable the safe and fluid transition from other existing services, whether that's in the community, but also within inpatients. So next slide, please. I think this is back to you, Rob.
Yeah, thanks a lot, Martin and John. Really useful overview there, the specifics. So just to kind of sum up and pull it together, and then we're happy to take questions. We're looking at giving a holistic, person-centred and very recovery-focused input to individuals in their own homes as an alternative to some of those residential and hospital placements that we've talked about. Pivotal to this is having choice in the area where people identify with and choose to be. So within the model, as John said, we've got links with various housing associations. So the mine workers will help facilitate that and hopefully get people into roughly the kind of areas where they want to be. So a lot about skills building and very practical stuff. And as Martin said, they're tipping this kind of model on its head. So it's very socially orientated rather than medically. Obviously, a big part of recovery is around having a sense of hope and a sense of agency. So that'd be foremost to the kind of psychological level. It is a multi-agency approach. We haven't referenced Forward Thinking Birmingham, but it's available to their 18 to 25-year-old patients. And then the other thing that we haven't quite mentioned, at the moment, the resource aids 10 people if full. The new model, there's going to be an investment from the system through other efficiencies and baseline spend. Instead of just dealing with 10 people in one place, we're proposing to deal with 50 people in the community spread across the city and Solihull. So it will actually expand the reach of the intensive offer to more people. So hopefully that's been of use and makes some sense. And we'll pass over back to the committee.
Right, thank you very much for the presentation. Those of you watching online who are observant will notice that Councillor Brown is no longer chairing this meeting. He has a long pecuniary interest in the matter. So I'm Rob Poker. I will be chairing the rest of this agenda item. And I've seen Councillor Clancy who wishes to comment.
Thank you. I can't see any faces on screen, so I just...
Mario, could you take the slides down for us, please?
I caught some voices, but that was all. So I don't know who I'm directing my questions to. I've just got two, really. Thank you for the presentations. One of the latest comments that was just made by somebody was obviously around the 10 people at Pershire Road, and obviously the offer will extend to 50 patients in the community.
Yeah.
Somewhere in the document we had in our papers, it talked about a block contract for £415,000.
Yes.
So I'm assuming a block contract for that amount is sufficient to cover the offer of 50 people in the community. I'm just trying to hear what people are saying and link up with what we would give.
Can I cover that one for you, Councillor Clancy?
Your screen presentations. That was the first question.
Yeah.
The other one was in the document we had in our papers, which was really covered a lot of what you said, but is more around the Pershire Road facility.
Yes.
It doesn't mention in the document timelines, and I'm sorry if I've missed it when you were talking. So I just wondered what we're talking about here today. What are the given timelines for that? And if people are under a Section 117 arrangement, and some are at the end of their sort of 18 months or at the infancy of their whatever short-term stay that is. How is that connecting and aligning with the proposal to close Pershore Road? Are they at a sufficient stage mentally, I suppose is my question, that I'm assuming some of the 10, if not all of the 10 people are, but are some not, in which case they will have greater input from those multi-agency people. So my first question was around the block contract for 415,000. Does that cover from the 10 to the 50 in the community? And obviously, secondly, is the timelines. And I suppose my third question is, which is rather blunt, and I apologise, was your hand forced by Midland Heart on this when you said in the presentation that Midland Heart wanted to disinvest?
Right. Thank you, Councillor Clancy. If I can cover off the first bit about the resource, can you hear me okay?
Yes, thank you.
Yeah. So the answer to that is, in part, the new service, which is an integrated service between the Mental Health Trust and the voluntary sector, will cost considerably more than 415,000. So it will be a contribution to that. I've had an assurance from the Mental Health Trust that they will find the remainder, which is probably in the region of 900,000. So we're talking about a provision that will be around about 1.2, 1.3 million, but we'll serve 50 people.
That's not common, that's assurances.
Yes, yeah, we've had that assurance, yeah.
Thank you.
From their board, yeah. Okay. I mean, in terms of the timelines, we've been a little bit stymied in terms of trying to get all the ducks in a row because it's quite complicated and one thing leads to another. So until we kind of get this bit rounded off that we can proceed, we haven't been able to give anybody real notice. So we're very much guided by your acceptance and other governance that we've been through in terms of giving us that kind of mandate really to proceed. And then we'd be working on around about 6 to 9 months mobilisation of the new team. And I think really good question, and it's something that we have thought about around the current residents. So all of them will be offered an opportunity to move into the new model. So to identify a tenancy for themselves and to be supported by that. If people don't feel that they want that or they're not able to cope with that, there is alternative residential care, both with Mind and with other organisations who are at least rated good or silver with the council. So there is other alternative residential care. And obviously we'd stop taking any new referrals once we've got that assurance that we can proceed.
Thank you.
The Midland Heart bit.
Do you want me to
I'll
pick
let
that up,
John come in there. Yeah. Well, thanks for the question. The straightforward answer is no. Our hands weren't forced because Midland Heart, we've been a managing agent. Birmingham Mind have been a managing agent for Midland Heart, and a number of other housing associations across Birmingham where we deliver care and support to people with different degrees of mental health needs. In terms of Pershore Road is one of 5 care homes that we currently manage, and we've been in consultation and discussion with Midland Heart for probably about getting on for 2.5-3 years about leasing or buying the buildings that they own. And which we manage on their behalf, and we've Pershore Road was on the list of those properties and was being considered for us to lease. We were never going to stop delivering the service at Pershore Road until our intention was to lease the building from
Midland Heart. We have an opportunity to purchase the building, as alluded to in the presentation. But circumstances have changed in the last couple of years in terms of some of the circumstances that we've provided, communicated to you this morning, this morning rather, around the limitations of the building and the difficulties and challenges that we're having in terms of that environment and attracting people into the home. I hope that clarifies the position.
Yeah.
Thank you for that contribution. I'm going to call in Councillor Tilsley and then Councillor Sloan.
Thank you. Obviously, any reduction in facilities within Birmingham, we have to look at very carefully because, as you started off the presentation by saying, you've been under considerable criticism by CQC as far as out of area placements are concerned, and it's something that's concerned me for a long time. So any repatriation that can take place to Birmingham or the West Midlands area has got to be beneficial, particularly considering the cost of some of the outer area placements, particularly the one at Northampton, I know, is costing an arm and a leg. However, if my memory serves me correct, the Pershore Road facility took over from the purpose-built facility at Money Hall, which didn't turn out to be fit for purpose for people with challenging behaviour, shall we say. When I look through the report and try to match up, you obviously haven't got 100% occupancy at Pershore Road, which is one of the reasons for the exit. A number of those people will be, through definition, to a certain extent institutionalised, and will require support. Now you've got, I counted up there 75 bed spaces in the self-contained flats. What kind of occupancy have you got in those? And should people not feel that independent living was for them, what capacity within the current establishment have you got to accommodate people?
Yeah, thanks, Councillor Tilsley. There's some really important points in there, I think. I mean, in terms of capacity overall in residential, I'm led to believe that during COVID it's actually reduced. So there is capacity. I think John would probably tell us the actual figures for his organisation, but not the whole mental health part of the residential care setup. So we're pretty confident there is alternative residential care for people if that's what people require and so desire. So John, can you just talk about that bit?
Yeah, no, again, it's a very good observation, I think, and something that we've spoken about. Yeah, we have for Birmingham Mind, as I mentioned, we have 4 of the care homes that we manage, and all of those are rated good, and we do have vacancies in 1 or 2 of those homes that we could make available as an offer, you know, as a choice to people who for whatever reason felt they were unable to move from Pershore Road, or even for that matter, when they're being discharged from hospital, going straight, into the proposed service. So we do have vacancies, but also we do have a number of supported housing properties around the city that we offer to individuals with support under the Supporting People programme, later currently being Vulnerable Adult Service, as it's going to change to become. So there is capacity in the system to pick up people and offer them some choice. I think that I go back to the points that I made earlier around the feedback we've had from service users has been very, very positive. I think because Pershore Road is up to 18 months rehabilitation, it does mean some people move on quite quickly. Actually, they don't always stay for the full 18 months. Some people, their recovery, their social recovery and clinical recovery takes a little longer. So that's why we have the 18-month period. But generally, people move on fairly quickly once they've, stabilised, once they, have a degree of confidence, and we are able to offer them, supported accommodation, either within our own provision or working with many other providers around the city, including a number of housing associations.
Thanks, John. Can I just come back in, Councillor Tilsley, just with another bit of information that would be of interest to you? The whole question of residential care and care homes with nursing is something that we've started working with our council colleagues. So working with Alison Malik in commissioning, there's the BICUP initiative, which is looking at all the joint commissioning arrangements for accommodation with support. So that's going to be very central and essential, really, in terms of how we move forward. Because I think, it's fair to say probably 4 or 5 years ago, the first aim of the council was to get frameworks and contracts in place for all the residential care and try and get standards up. I think Alison's view is we're ready to move on from that now, and there's an opportunity, and there's kind of planets are aligning for us to have a look at kind of specialities within that. And of course, mental health would be one of those specialities. So we've got a workshop lined up on March the 8th, which is kind of going to set the parameters of that work and get that underway. But it is something that going forward and within the provider collaborative as well, when that comes in as part of the ICS, that, we really get our ducks in a row on this, because as I alluded to earlier on in the presentation, it's been a very fragmented picture for a number of years and very piecemeal, where providers have just sort of set up places rather than being through any kind of strategic requirement. So that's where we're all sort of trying to get to.
Yeah, I'm aware of the range of the offer. I've worked Rathbone in the past, so I know the broad range.
The final question from Councillor Islam.
Thank you, Chair. Just a very brief question. Housing stock, which already been mentioned, the mine has included the proposal, which is golden, which is the citizen. These are the one of the housing institution can cater 29 of the the people. So this is the good news. But the next one is about finance. It's a very big one. You mentioned about it anticipated that funding of people will be paid by the patient through housing benefit. So you mean that each patient they will apply for housing benefit through the city council. For some reason, if they do not get it because of the financial circumstances, So what would be the consequences of that? Thank you.
Okay, sorry, I didn't catch the first part of the question, Councillor Islam. I mean, in terms of the housing benefit one, I did catch that. I mean, this happens anyway. Once a person moves on from a kind of residential accommodation, they're eligible for housing benefit. So being a citizen, they would, you know, take up that part of the benefit system really to fund the actual property.
Sorry, can I just the first one again?
Yes,
I do not like an explanation just to clarify.
Yes.
Because citizen of the one of the housing petition can cater. One is citizen is small heat, they can cater 22, and the Midstead Addington 7, you know, the 7 self-contained flats. So there are 29, which is the biggest one. So I think this is a good news. If the mind can allocate all this in, you know, in on time, you know. So this is my.
Yeah, I got that. So these are the existing mined properties with support, and John could say a little bit more about those. They've both been in existence for, you know, very long periods of time, probably going back to the early 90s, I think. So they're kind of part of the model. So we've already got them, and then what we want to do is build on top of them, is to have other tenancies as well. So there's various housing associations that Mind have got affiliations with. And John, again, if you could just outline those.
Yeah, no, absolutely. Thank you. I think the two accommodation schemes that council is referring to is the one Golden Hillock Road in Small Heath, which we've managed for many years. That's owned by Citizen Housing. We have managing agreements with Citizen Housing, Bromford, Adullam, Midland Heart, and we're looking to increase the opportunities to work with housing partners. To that end, I have actually made some inquiries of the Bishop Group. You'll be familiar with the Birmingham Social Housing Partnership group in respect of other potential partners that would come on board, other housing associations, to provide accommodation from their own stock. Because clearly one of the things we want to be able to offer is accommodation in the areas that people want to live. And this is another important factor, I think, in this initiative, that actually a few of the people that come to Pershall Road are not living in their own communities. You know, so part of the initiative, part of the redesign, is to get a range of accommodations with housing providers around the city, so people can connect up with their communities, which is really important. And we have, as I say, a number of partners we're working with, and we have quite established housing stock in which to provide support for people, that wraparound support, and working with our clinical colleagues. So I personally don't see, that there will be potentially any real issues there. And as I said a moment ago, we're looking at 50 individuals, and the soundings I've made with the Bishop Group are very positive, and they would be a key partner as we move forward. I hope that answers the question.
Yeah, I'd like to thank you as presenters. We need to move on now. You have invited us to take a view on this proposition, as whether this committee is supportive of this re-provision or not. I'll take a steer from members. Are we supportive of it? Let's just see if we're in favour of it in principle. And we've got some caveats, I think. Councillor mentioned the finances, so I think we're giving conditional support, but we'd like to be reassured about the financial viability of this new model. I think we'd be keen to hear more about the content of the consultation that you've carried out. I'm sure you've got an internal note of how you consulted on options before coming to a final decision. Yep. We're very concerned as a committee that we go through proper consultation procedures and not just present people with a fait accompli. So I think we'd like reassurance that that has been carried out, and maybe you could come back in a letter or communication to advise us A on the finance, B on the consultation, see that you've got enough other provision for those people who do want to have the supportive infrastructure they've got currently at Pershore Road.
Thank you very much. We'll be happy to do that.
Yep. Thank you.
Unless those conditions, I think we're supportive in principle, we'll wait to be reassured of those other points. Thank you very much. We've concluded that.
Thank you.
Thank you.
Thank you very much.
Return hopefully to Dr. Marion Gibbon, who's going to present on infant mortality.
I'm period poverty is what I've got down to.
See, that's up my mind already. I need to pass the chair on. You can see to Councillor Brown, who will take back on agenda item 6 on period poverty. Thank you.
Okay, thank you for that, Rob. I appreciate that. So we're coming down to the poverty and raising period awareness report.
Yeah. So this is the tracking report I had presented previously, and this is to update you on progress with each of the recommendations that were set out. So in terms of recommendation 1 is already complete. Recommendation 2 was regarding the council declaring its support for the pledge around period poverty and initiating a programme to tackle stigma. The cabinet member assessment for this has been undertaken, and it's now at 2. A paper outlining the pledge went to the corporate leadership team for discussion on the 28th of February of this year, and they have now reviewed, the council has now reviewed the family-friendly offering as part of that review, and that has been produced and approved by cabinet for it to be implemented with the health and wellbeing passports. And in addition to this, progress has been made through a series of period equality articles that have been begun, covering menstruation and disability within the LGBTQ plus community, pregnancy and postpartum, perimenopause, and so forth. I'm not going to go through the whole of it, as you already have the paper with you. Articles have been co-produced with the internal staff of the Diversity Alliance networks, and we are exploring opportunities to provide free period products for all BCC employees in all council buildings. There's discussions that have been undertaken with HR around the policies in terms of time off for staff for issues relating to menstruation, and links have been made with the West Midlands Combined Authority, as well as the Thrive at Work programme, and all this will be fed into the workplace health and wellbeing accreditation that addresses period poverty. And this will continue to take place even now. It's now achieved, but achieved late. So with the next recommendation was to look at the feasibility of commissioning research on the topic of period poverty. So what we've undertaken with regard to it, a request around feasibility, we've got 2 areas of work that are have been explored and there is some feasibility, although it will not be undertaken very necessarily all of it very quickly. But there are two places where we will be looking at periods and period poverty. One is in relation to the seldom heard community research project, but that will not be the first piece of work that they undertake, because there's also already a piece of work that's been agreed on the area of cultural competence, which is priority number 1. But so period poverty will be the second piece of work area. But the other piece of work that will be undertaken is this month with some schools in West Birmingham, when on the topic of periods that's going to take place with some of the schools in West Birmingham. But regarding, as this was a kind of looking at feasibility of undertaking work, even though this has been looked at and seen as a 3, and so we've not therefore not being achieved, I feel this is a little bit unfair, because what we were asked to do is look at feasibility, and we have actually undertaken looking at feasibility and have actually stated there are two ways that we will take it forward. The fourth recommendation was about how we establish a more collaborative approach to our work and supporting third sector organisations. And a lot of work has been undertaken around this. And this work will continue. However, a lot of this work will be undertaken within the housing agenda, and therefore housing are now going to have agreed that they will be reporting on this last element in terms of number 4. Number 5 is looking at our procurement processes and considering how we include this in our future contracts, and this is now being completed. There is a charter guidance document that's about to be published, and this will be available on our BCC website pages and available to all bidders. So, and it will be, all of that information will be posted via the social value channel, which is used to inform commissioning and promote procurement colleagues and make sure that they do include, when relevant, period poverty as a specific area for attention in their social value specification. So there you are in terms of where we're at.
Okay, thank you very much for that. Rather than what we would normally do is ask individual members to ask questions, I think if we actually go through each individual recommendation and then ask members to ask questions on that recommendation. So we start with recommendation 2. Does any member have a question to ask on that recommendation? Or are we happy with that? We're okay with that one?
Yeah.
Okay. Are we happy to leave that at a cabinet assessment of 2? Okay. We're okay with that one then. So if we then come on to recommendation 3, do any members wish to ask a question on recommendation 3?
I guess my comment there would be, I think we'd still like to see a point where the possibility of commissioning a proper piece of research could be carried out. I know you've obviously talked to one of the several groups, another group will hold a focus group. Where we'd like to get to is that there would be at some point a piece of research that could be carried out, and make the point that's in the recommendation, establishing the nature and extent of period poverty in Birmingham. This isn't easy to do, I appreciate that. The recommendation is 3, that it's not completed. I think we would support that cabinet member recommendation, actually, that we shouldn't discharge this item, but we should look over the next period to see whether such a research project could be put together?
I understand your what you're highlighting here. However, I have put forward two areas. I will be producing a report from the focus groups that are undertaken in school, and it will become part of our seldom heard community research work, and that is what I'm able to say is possible at this moment in time. With regard to future research, the feasibility at this moment in time, this year, it would not be necessarily a priority for us because we have an awful lot of work that we are undertaking this year. We can look into whether it becomes feasible as a research project for 2023, given that is the year of the child, and you could consider this as a piece of work that would come under of a piece of work that would be possible within that year of the child.
Okay, thank you for that. And that's the question. You identified one of the schools in West Birmingham will be holding the focus group. Has that school been identified? You narrowed it down?
I've had some discussions with them, and the dates have been set up. Yes.
Okay, are we able to share the dates with us in terms of when that's going to start and finish?
Yeah, I need to look at emails on that because it's only just been agreed this week, and so which is why I hadn't got it all in my report. Okay,
could I ask you to feed that back to Kelly when you can clarify those dates for us?
Yeah, certainly, most definitely, yeah, definitely.
And then a short report to be fed back to HOSC. Do you have any timescales of when that's likely to happen?
So that once the focus groups are undertaken, we will endeavour to get that short report completed within the 2 weeks, so I can put that whole time frame together for you and send it to Kerry by the end of today.
Okay, thank you for that. So in terms of the Cabinet Members Assessment Committee, are we happy to stick with a score of 3? Yeah, okay, so thank you for that. And if we move on to recommendation 4, any members have any particular questions they want to ask regarding that recommendation? No, okay, and again, are we happy with the Cabinet Assessment of 3? Yeah, okay, so thank you for that. And then that comes on to recommendation 5. Do any members have a question regarding recommendation 5? Okay, could I ask a question myself then? Is in terms of the block font, it says for organisations possibly consider donating products to food banks and working with schools. If organisations choose to donate, is that fine? But what scope of organisations have to say, well, yeah, it's a possibility, but I'm just not going to do it because I don't. My organisation doesn't want to do it. I suppose what I'm saying is that consider donating appears to be a bit generous a term to include from my own personal perspective.
I know that when I've spoken to schools around the amount of period projects that they have available for kids, they said they could paste all their walls with them. They have a lot.
Okay. That's fine then. That's any questions to ask on that?
Well, just being particular about this, the recommendation is very specific. It's commissioned, in other words, it's already been commissioned, to include a clause about alleviating period poverty. I would have seen that as a condition of contract rather than to put it on the website related to procurement. So I wonder if we could look a bit further about whether that could be a condition of contract once the procurement has been completed, rather than simply pasting a wish list on the procurement website. The other point I would want us to be keen to look at is when we assess bidders, there is a social value element now in bid assessment. Could we be assured that their period of poverty and/or could be included in the weighting that is scored when the social value of a bidder is considered? So it's actually not just in the invitation to tender stage, it's in the bid assessment stage, where weighing up different bidders, that the social value of a bid is now assessed. One of the components of social value could be whether they've done a big push on serious awareness or something like that. So it's two additional steps to comply with recommendation 05 in my view.
We just support that particular line.
Which means we will give it a 3 and ask procurement and we'll ask contracts, which bit of the council will have to consider that. Will we ask them to address that question?
Yeah. How much they will be procurement? Do you have a further comment on Councillor Pocock's question?
I think it's as you say, it's commissioning and procurement colleagues that would need to update you on that. That once that element is completed.
Okay. And in terms of Councillor Pocock's suggestion regarding moving that cabinet assessment to 3 rather than 2, are people supportive of that? Yeah. So can you put your hands up? So then we would leave all of the recommendations as they are, apart from recommendation 5, which would look to potentially move to a score of 3 rather than 2. Agreed. Okay. And could I ask, in terms of when you'll be looking to report back to the committee again? Have you got a set date or a time scale?
There's a date set for August, but I feel that it needs to be more than public health now, that it needs to come from, there needs to be somebody from procurement who comes and reports on that bit. The part from public health pertains to the recommendation 3, and I will ensure that a report, once the school's work is undertaken this month, that comes to you, and then that will finalise that element, and then I will be able to discuss with Justin the feasibility of a piece of research. But I know that it will not be viable to undertake this year because of the immense amount of work that we've got around this recommissioning of our 0 to 19 services and so forth. So it would definitely be not taking place until the year of the child, that piece. So I just want to be guided by you in terms of how you want to have that report on recommendation 3.
Any further comments in terms of how we want to move that forward? Would we want to wait until the year of the child, or we want to do something later this year?
So there's a date. Well, I think the practicalities are, Chair, that it will need to be 2/23. Something quite good about tying in with the year of the child anyway. So I'll be content with that element coming back to us in the 2/23 cycle, but the procurement coming back to us as was planned in, was it August?
August time, yeah. So you're happy that we look for the 2 options of coming back for the year of the child, but also for the procurement in August as we'd initially envisaged? Are we all happy to do that? Yeah. Okay, so in terms of are there any more points that you would want to make the committee aware of?
I think that I will send you the timeline around the piece of work for work with the West Birmingham schools, and then that will sign off half of that, and then if, as Councillor Pocock has said, a piece of research that we look to ensure that the report is available within 2023, which is the year of the child. That seems feasible.
And do you envision the time within the year of the child where you'd want to make that report, towards the beginning, middle, or end?
I think I need to speak to the Health and Equalities team, because that doesn't come under me. If it came under me, I would be able to be more specific, but I need to discuss it with the Health and Equalities team before I can give you a specific timing on that.
It's just been brought to my attention, there's no HOS committees in August and September. So I'm just wondering whether it could be done before August, or would we go into the autumn time? So those points just need to be borne in mind when you consider coming back. Yeah.
Okay. Well, it'll be procurement for that, but I can make sure that that report is available to you from the school's work prior to the next committee meeting.
But if you could possibly negotiate through Kerry and Gail in terms of the exact dates.
Yeah, sure. That would be great.
Well, unless anybody else has got any particular questions or points to raise, can I thank you very much for your involvement and your contributions today.
Thank you.
Thank you. Thank you.
Thank you.
Okay, so that brings us next down to our work programme. Do members have any comments on the work programme they want us to look at or note? Okay, thank you for that. Any requests for call-in? No. Council action? No. Urgent business? No. Authority to chair until the next meeting? Thank you for that. And just a bit to whet your appetite, the next meeting's on the 29th of March, again here in person in Committee Room C, and we have the pleasure of the Cabinet Member for Health and Social Care, along with Dr. Justin Varney, the Director of Public Health, and an item on the Neighbourhood Network Scheme and the Adult Social Care Performance Monitoring, Quarter 4. And always an item of interest for people. Okay, thank you very much for your time, and enjoy the rest of your day. Thank you.